Okay, let's get into the meat of the antipsychotic. Okay, we're going to get into antipsychotics and some major concepts. We have the first generation and the second generation antipsychotics. The first generation are referred to as typical or conventional antipsychotics. Uh, the second generation are referred to as the atypical antipsychotics. And there may be the beginning of third generation antipsychotics as well. The first generation antipsychotics block D2 receptors throughout the brain. And in doing so, they help decrease the positive symptoms, but they also increase the negative symptoms. And this, of course, can create a lot more problems. The second generation, the atypical antipsychotics, are not only D2 antagonists, they are also 5-HT2A antagonists. Because of this, the impact on negative symptoms may be lessened. Problem is that the atypical antipsychotics can cause metabolic syndrome complications. Things to keep in mind as we're going along are the receptor binding strength, whether the actions are agonist or antagonist, which neurons bind with which receptors, and what region of the brain are we talking about. This is the gear shift image. This shows the receptor binding properties of the atypical antipsychotic. The drug is the blue sphere. The drug's most potent binding properties are depicted on this outer edge. The different colors refer to a different binding property. Let's see if this slide will show me some boxes. Okay, there we go. Histamine, first we saw muscarinic and then histamine, adrenergic, alpha adrenergic receptors, certain net transporters, dopamine receptors. Here we have the serotonin receptors. So the binding strength for a particular receptor is depicted by the size of the box and how many plus signs are present. Those with a stronger binding affinity are positioned on the left with a larger box and more plus signs. The weaker binding affinity will be demonstrated by the position on the right with a smaller box and less plus signs. You will also see a vertical dotted line that will cut through the D2 receptor box. The binding properties are more potent than D2 on the left of the dotted line and less potent than D2 to the right of the dotted line. Binding properties are based on mean values of something called K1 data. K1 refers to binding affinity. So this gives us a visual of how strongly a drug binds to the receptor, and it is a way to compare atypical antipsychotics. So what makes an antipsychotic conventional? And primarily it's the D2 antagonist actions. The first generation antipsychotics are classified by how tightly a medicine binds to D2 receptors, high, medium, or low. High potency antipsychotics, we find that there are more dystonias. Low potency antipsychotics, we find more anticholinergic properties. So the first generation antipsychotics came about in the 1950s, sometimes referred to as non-surgical lobotomies. And they are not used as often today because of the side effect profile. You're almost guaranteed that the patient will eventually get tardive dyskinesia. The list here are the first generation common antipsychotics. So here we're looking at some schizophrenia theories. Too much dopamine in the mesolimbic pathway results in positive symptoms of schizophrenia. When you give D2 agonist, then that will um, reduce the amount of dopamine and reduce the positive symptoms. Too little dopamine in the mesocortical area results in negative symptoms and cognitive and affective blunting. So when you give a D2 antagonist, you're blocking dopamine from binding to the D2 receptors. You're decreasing hyperactivity in the mesolimbic pathway, which is decreasing the positive symptoms. You're also decreasing it in the mesocortical pathway, which is decreasing the, which is increasing the negative symptoms potentially. So the hypothetical threshold for the conventional antipsychotic to be effective needs to be about 80%. If it's more than 80% in the area of the dorsal striatum, this is going to result in EPS. If it's more than 80% in the pituitary, that's going to result in hyperprolactinemia. So with the conventional antipsychotic, the same number of D2 receptors are blocked all over the brain. Okay, this is showing us the mesocortical pathway. You give a D2 antagonist, and you can worsen the negative symptoms. In the nigrostriatal pathway, shown here, this is typically not affected in schizophrenia. However, if you treat it with an antipsychotic which blockades the D2 receptors, you will end up with EPS. Long-term blockade here causes upregulation of the D2 receptors in the neurons as they attempt to overcome the drug-induced blockade of its dopamine receptors. This results in tardive dyskinesia. And that's what's happening in this slide. In tardive dyskinesia, we have facial movements, tongue movements, jerky limb movements. Fortunately, now there are some medicines available that will treat tardive dyskinesia. This is a tuberoinfundibular pathway. In untreated schizophrenia, it is normal. But if an antipsychotic, a typical one, is used to treat schizophrenia, it prevents the dopamine from binding to the D2 receptors in this area. That results in an increase in prolactin, and that can result in galactorrhea and amenorrhea and gynecomastia. So this picture here is showing us the binding properties of the conventional antipsychotics. We see D2 antagonism. We see that the M1 or muscarinic cholinergic receptors are blocked. We see that the histamine or H1 receptors are blocked, and the alpha 1 adrenergic receptors are blocked as well. And so when the muscarinic receptor is blocked, this can result in side effects such as constipation, blurred vision, dry mouth, and drowsiness. So in the nigrostriatal pathway, shown here, dopamine and acetylcholine have a reciprocal relationship. So the dopamine neurons connect with the dendrite of the cholinergic neuron, and so dopamine suppresses acetylcholine release and activity. So that's what goes on normally. However, if we're using an antipsychotic, the dopamine receptors on the cholinergic dendrite, which were on the left of that diagram, then acetylcholine becomes overly active, and the increases the release of acetylcholine on the right, and that causes EPS. There are attempts to compensate with this with anticholinergic drugs blocking M1 receptors to decrease the EPS. So, not uncommon for first-generation antipsychotics to cause extrapyramidal side effects, including dystonia, pseudoparkinsonism, tardive dyskinesia typically occurs with everyone who are on first-generation antipsychotics for a length of time, and it typically becomes permanent and irreversible. The second-generation antipsychotics, there is a 7% chance of tardive dyskinesia, but akathisia is also pretty common. I tell patients that they feel like they have to move around or their feet gotta dance. So they feel like they're very restless and jittery and they have to move around. They might describe it as anxiety, so you may need to tease it out whether that's akathisia or actually anxiety. Other side effects include tachycardia, postural hypotension, sedation, weight gain, amenorrhea, gynecomastia, and galactorrhea. So what makes an antipsychotic atypical? And what you need to do is combine a D2 antagonist with a serotonin 5-HT2A antagonist. So the second generation antipsychotics were developed in the 1980s. Clozaril was the first one. They treated both the positive and the negative symptoms to some extent. Supposedly less side effects, but what we found out was the side effects were a bit different because now we found metabolic problems. So second generation antipsychotics can cause metabolic syndrome, including insulin resistance, weight gain, increased lipids, and increased waist circumference and BMI. Another way to classify the second generation antipsychotics comes from Dr. Stephen Stahl, and he has broken them down into the peens, the downs, and 2 pips and a rip. In general, the peens are much more sedating, and there tends to be more weight gain with this group. The downs need to be taken with food, and the 2 pips and a rip tend to be more activating, especially in comparison to the peens. Okay, so some things that we're going to talk about. We know that antipsychotics block D2 receptors and that it goes on throughout the entire brain, causing side effects. We need to pay attention to what receptors, where they are, how they're interacting with other receptors, and where. What we will talk about further, 5-HT2A stimulates glutamate receptors that stimulate GABA receptors that in turn inhibit and decrease dopamine. 5-HT2A antagonism stops the glutamate activation. That in turn stops GABA activation, and that in turn increases the dopamine. 5-HT1A has partial agonist actions. 5-HT7 has potent antagonist actions. And we also have something called dopamine partial agonists as well. Okay, this is simply a review of how serotonin is produced. We see the tyrosine, precursor amino acid, and tyrosine has its own trolley that comes into the neuron, and with the help of an enzyme, changes the 5-HT into 5-HTP. Excuse me. And then the 5-HTP is stored in vesicles until it can be released. And then 5-HT or serotonin action termination occurs with MAOB internal to the neuron, and external to the neuron occurs with either MAOA or MAOB. Okay, so when we have an atypical antipsychotic that includes 5-HT2A antagonism, the 5-HT2A receptors on the glutamate pyramidal neurons are blocked, and so GABA release is not stimulated, and dopamine is not inhibited, meaning that the dopamine release increases. And there it is. There is also 5-HT1A receptor stimulation, which increases dopamine release. So 5-HT binds to 5-HT1A receptors, which inhibit glutamate, which means GABA release is not stimulated, and so this results in dopamine release not being inhibited, and so there is an increase in dopamine release. So in the nigro and striatal areas, there is 5-HT2A receptor stimulation that results in a decrease in dopamine release. So serotonin binds to 5-HT2A receptors on the GABA neurons, and that increases GABA release, and that in turn decreases dopamine release. Also, 5-HT binds to 5-HT2A receptors on the dopamine neurons. That also decreases dopamine release. 5-HT is also released in the raphe nucleus, binding to the 5-HT2A receptors on GABA interneurons, also resulting in a decrease in dopamine release. the Rathe nucleus. Oh, so let me clarify. At the Rathe nucleus, 5-HT receptors on the GABA interneurons are blocked. So there is no increase in GABA activation, and so the dopamine release is actually increased. So in the nigrostriatal pathway, normally 5-HT inhibits dopamine release. In this example, there's no 5-HT present at the 5-HT2A receptor on this neuron. And when 5-HT occupies the 5-HT2A receptor on a dopamine neuron, it inhibits the dopamine release. And so postsynaptic D2 receptors are blocked by the serotonin slash dopamine antagonist. So there's dual action of D2 and 5-HT2A blockage. The 5-HT2A antagonism reverses the first action of D2 antagonism. So dopamine is disinhibited and it is released. So the D2 blockade is reversed, resulting in little or no tardive dyskinesia or EPS. We also know that here we see dopamine inhibiting prolactin release. 5-HT stimulates prolactin release from the pituitary. And so dopamine and 5-HT have reciprocal actions on the prolactin release. The 5-HT2A antagonism reverses the abilities of the D2 antagonism, and so prolactin release is not increased. So thresholds, hypothetical threshold for atypical antipsychotic effectiveness. The D2 receptor occupancy needs to be greater than 80% in the mesolimbic pathway, but the nigrostriatal and pituitary D2 receptors are only occupied at 60%. This is due to 5-HT2A and 5-HT1A properties of the atypical antipsychotic. Okay, here are the boxes that I was talking about. And here we're looking at the group of antipsychotics referred to as the penes, which tend to be more sedating. We have clozapine, olanzapine, quetiapine, and asenapine. There we're looking at the vertical line going through D2, and to the left of the line there's an increase in binding potency, and on the right binding properties are more potent. Okay, so binding properties are more potent than D2 on the left and less potent than D2 on the right. In addition, the penes bind more potently to the 5-HT2A receptor than to the D2 receptor. So this is also true for the domes. So there you can see that all four of these drugs bind more potently to the 5-HT2A than to the D2 receptor. Okay, so this slide is just showing you the 5-HT2A binding by the dones. There you see D2 for each drug, the vertical line. And again, for all of them, the 5-HT2A binding is stronger. And the 5-HT2A binding by the 2 pips and a rip. Okay. There's the vertical line showing you D2. And in this case, the D2 binding is stronger than the 5-HT2A binding. Okay, so here we have the presynaptic 5-HT1A autoreceptors located on the cell body and the dendrites. Serotonin binds to the 5-HT1A receptors. It shuts down the 5-HT neuronal impulses. So there's less electricity flowing through, and there's a decreased release of 5-HT from the synapses on the right. This is giving us information about the 5-HT1A binding by the penes. Again, we see the dopamine, and we see the differences in the 5-HT1A binding. Again, 5-HT1A binding by the dones. There's the vertical line, the D2, and the D2 binding is much stronger in some of them than the 5-HT. See the bigger difference here on the bottom with lorazepam. The 5-HT1A receptor binding is about as potent as the D2 binding. So lorazepam is certainly different than the other dones. Here we have 5-HT1A binding by 2 rips and a pip. And again, we see more 5-HT1A potency, very similar to the D2 potency. And we continue. This is showing us the 5-HT1B and the 5-HT1D binding. And again, we go through the penes. I'm going to go through this a little bit faster. And then the dones. And 2 pips and a rip. Cariprazine doesn't have any receptor binding with 5-HT1B or D. And 5-HT2C, same principles, showing you the same processing going on. 5-HT2C binding by dones. And 2 pips and a rip. And there is also 5-HT6 and 5-HT7. Here are the penes, the dones, 5-HT7, if you recall, is believed to have some benefit on cognition. Okay, so what makes an antipsychotic atypical? Uh, it can include drugs that are D2 partial agonists, which we see depicted here. These drugs stabilize dopamine transition in a state between silent antagonism and full stimulation. So we're looking at what we call a spectrum of dopamine neurotransmission from too cold, so where the conventional antipsychotics bind to D2 with powerful antagonist actions and prevent agonist actions, decreasing positive symptoms but causing EPS, all the way to the opposite, D2 receptor agonists, too hot, causing positive symptoms of psychosis. And here we have the D2 partial agonist binding in an intermediate manner to the D2 receptor, so that the antipsychotic actions are just right with no EPS. And this is referred to as the spectrum of dopamine neurotransmission. Here's another depiction of dopamine receptor output. Here would be in a normal state at the top. In the middle, we have D2 antagonism. So there's very little receptor output. And here we have DPA, D2 partial agonist, partially activating the dopamine receptor for output, and it causes a stabilizing balance. So we go from the full agonist, where we have robust signal transduction through G protein linked second messenger system of D2 receptors. We have antagonists, where the receptor does not conform and is not capable of signal transduction. And then we have dopamine partial agonists, where there is an intermediate amount of signal transduction. So this is showing us the spectrum of dopamine partial agonists. Some are silent antagonists to full agonists. The two rips in a pip are closer to the antagonist end of the spectrum. So keep in mind that drugs in this class interact with other receptor subtypes, and there are no two atypical antipsychotics that have identical binding properties. They are all completely different. Here we're looking at possibility of antidepressant actions by an atypical antipsychotic, and you can see that it's the partial agonists have an effect on the receptors of 1A, 2A, BD, 2C, 3, and 7, and that makes them very likely to be able to help with depression. In addition, this depiction shows us anti-manic actions, specifically D2, 5-HT2A, and 5-HT1A. But also the same ones resulting in the problems with cardiac and metabolic syndrome. They are also believed that in some cases there are anxiolytic and sedative hypnotic action because of action at these receptors, as well as these receptors. So there is binding to alpha 2 receptors, and that is believed to help with anxiety and also cause some sedation. You can see that that is not present on the brexpiprazole or the cariprazine. So cortical arousal throughout the brain actions at acetylcholine, histamine, and norepinephrine receptors influence arousal. And so antagonism of M1, H1, and alpha 1 result in sedation. And here again we go through the antihistamine and anticholinergic binding properties for each group of drugs. So of the penes, the clozapine, olanzapine, and quetiapine do have a strong potency for H1 and M1. Acenamine has a decreased affinity for H1 and a decreased affinity for M1. Of the dones, all have some potency for H1 receptors, but less than for the D2 receptors. And lorazepam does not bind to H1 or M1 at all. 2 pips and a rip, they all bind at H1, but less potency than for D2, and they do not bind to M1. The alpha 1 binding, here we have the penes. There's some alpha 1 binding for all of them. For the dones, there's alpha 1 binding for all of them. And the same for the 2 pips and a rip. Okay, now let's get into more specifics about each of these drugs. Olanzapine, typical dosing is 10 to 20 milligrams at bedtime. It can be started as low as 5 milligrams, and there are occasions when it can be dosed as high as 30 milligrams daily. It can be given as an injection. It causes potentially a great deal of weight gain and metabolic syndrome. There's a strong potency at H1 and 5-HT2A receptors, so it can improve mood and cognition. The weight gain can be quite dramatic, and so if someone is susceptible to that, they could potentially gain 20 pounds in less than a month. Quetiapine has different actions at different doses. Small doses result in an anxiolytic effect and can help with sleep. Larger doses help with depression, and the largest doses will tackle the psychotic symptoms. There are large H1 antagonistic properties, so it will help with sleep. There's also 5-HT1A partial agonist, NET inhibition, and 5-HT2C antagonist actions. These improve mood and enhance cognition. Here we're looking at D2 receptor occupancy at doses of the quetiapine at 300 milligrams versus 800 milligrams. And so at doses of 300 to, doses over 300. So 300 to 800, we're using this medicine as an antipsychotic. Doses of 150 to 300, we're using it as an antidepressant. And doses up to 150 are being used as an anxiolytic or a sleeping medication. Here we're looking at the quetiapine immediate release 50 milligrams and the quetiapine XR at 50 milligrams on the different receptors. And here at the 300 milligram dose for each and the 800 milligram dose for each. Acenapine also has indications for teenagers. It's typically dosed as at 5 to 10 milligrams BID. It is something that will dissolve under the tongue. There is to be no food or drink for 10 minutes afterwards. Problematic because it is not known to taste very good. There is moderate sedation, moderate weight gain risk. It also has a very complex binding profile. It is a 5-HT2C antagonist and a 5-HT7 antagonist. So serotonin normally inhibits dopamine and norepinephrine release via the 5-HT2C receptors. However, 5-HT2C antagonism disinhibits release of both norepinephrine and dopamine. And there you see it. Zotapine is not a drug that we are using in this country, so we are going to skip over this. Risperidone is commonly used. It can be given as low as 0.5 milligrams at bedtime, but most commonly 1 to 4 milligrams at bedtime. In some cases, you can try it BID if it's not too sedating. You can go as high as 6 milligrams. It does have moderate metabolic risk, and there is dose-dependent galactorrhea and gynecomastia. It does have FDA indication for use for irritability and aggression associated with autism. Haloperidol, typically the dosing goes up to 6 milligrams once a day. There is a moderate metabolic risk. It is also used as an injectable. It is known as Invega Sustenna, and in that case, it is very similar to risperidone. Ziprasidone is dosed at 20 to 80 milligrams twice a day with food. Again, if it's too sedating, it can be given just at night. You can titrate this drug rather quickly. One of the problems we find with this drug is QT prolongation. So you do need to watch what you might combine it with. For example, citalopram with ziprasidone would be contraindicated because of the risk of QT syndrome, prolongation syndrome. It can be given as an injectable. Tends to have less weight gain, less metabolic syndrome, and less sedation than some of the other ones. Iloperidone is also known as Fanapt. Dosing is 6 to 12 milligrams BID. This one you don't see as often in clinical practice, but it's available. It has moderate metabolic risk, and its profile is actually pretty simple. So cortical alpha-1 receptors may decrease dopamine release. There we see the pyramidal neuron. And blocking the cortical alpha-1 receptors may increase the dopamine release. Okay, lurasidone is also known as Latuda. Dosing typically is 40 to 80 milligrams. The average effective dose is somewhere around 60 to 80 milligrams, but you can start as low as 20 milligrams and you can advance up to 160 milligrams daily. This drug should be given with food. It is more effective with food. There is a low metabolic risk. There is an increased risk for akathisia, so if you can dose it slowly, you can help to avoid that. It binds to the D4 receptor, which we don't know much about, or we don't know anything about it. It also binds to 5-HT7, which can help with mood, cognition, and sleep. Here we're seeing the stimulation of the 5-HT7 receptors in the raphe nucleus, which reduces the serotonin release. And blockade of the 5-HT7 receptors in the raphe nucleus increases serotonin release. There's also a reduction of glutamate release from the pyramidal neurons because of the stimulation of 5-HT7 receptors in the prefrontal cortex. And again, blockade of the 5-HT7 receptors will result in an increase in glutamate release. Okay, so aripiprazole, also known as Abilify, is dosed differently depending on what you're using it to treat. It has a lower metabolic risk, although it is possible to gain weight on this drug. There is a higher risk of akathisia if you increase the dose too rapidly. It is a partial agonist at D2 receptors. If you are using this as an adjunctive medicine in the treatment of depression, the dosing would be 2 to 10 milligrams, often very effective at 2 milligrams, and you will often see a response in less than a week. If you are using it to treat bipolar problem, mania, or perhaps intermittent explosive anger, you need to get the dose closer to 10 to 15 milligrams. However, it doesn't actually have FDA indications for this treatment. Doses 15 to 30 are used to treat schizophrenia symptoms. Brexpiprazole, also known as Rexulti, it also has FDA indication to be used as for the treatment of depression in doses of 0.5 up to 2 milligrams. And it's also used to treat schizophrenia in dosing of 2 to 4 milligrams. There tends to be less weight gain, although it is still possible, less metabolic syndrome, and less sedation, although most people take it before bed. And then cariprazine, also known as Vraylar, currently has indications for the treatment of schizophrenia at dosing of 1.5 to 6 milligrams once a day. It also has FDA indications to treat mixed mania in doses of 3 to 6 milligrams. Clozapine is the most complicated atypical antipsychotic that we have, and you can see why looking at the diagram. If you are going to prescribe clozapine, you need to do a short in-service training online, something called a REMS program to reduce risk, where you are able to go in and document your patient's lab work regularly, which is required if someone is taking clozapine. Dosing is 150 to 300 milligrams BID. It is recommended to be used in the more resistant cases, but it is also recommended to be used as the third line agent if the first two haven't worked. Most people wait longer than that to administer it, and there's some practitioners who recommend initiating it more quickly. There is a high metabolic risk. The other risk is for a granulocytosis, and so it needs to be done, the labs need to be drawn weekly for 6 months, and then biweekly for 6 months, and thereafter once a month. And if the lab work is not done, the pharmacy doesn't get a copy of it, they will not dispense the clozapine. This is a nice chart that gives you a comparison of the metabolic effects of the atypical antipsychotics. It's important that you monitor for metabolic syndrome on a routine basis with these drugs. With clozaril, you need to watch out for a granulocytosis by doing the absolute neutrophil count and documenting it in the REMS program. Blood work is done. A CBC with diff is drawn weekly for 6 months, and then every other week for 6 more months, and then monthly for as long as the person is on the medication. Those who are prescribed olanzapine, sometimes this is prescribed during an inpatient stay where the person is not permitted to smoke. And then when they are released, they start smoking, and what will happen is that the smoking will inhibit the metabolism of the olanzapine, and it will no longer work as well. Ziprasidone concerns are a very serious eosinophilia systemic rash that can be very dangerous, and also for QT prolongation. Just a different depiction of the metabolic highway and how we need to take responsibility to be monitoring this if we are prescribing antipsychotics to our patients. It is hypothesized that the metabolic syndrome may be related to insulin resistance and perhaps tissue actions at an unknown receptor. We need to monitor. Here's a nice little flow chart. Some EHRs will do this for you. What can you do about it? You can try to change the antipsychotic. You can encourage the person to look at their lifestyle or diet, and there are currently practitioners recommending that you either initiate medicines to help with the weight gain, such as metformin, or that you collaborate with the patient's primary care doctor and see to it that this problem is not ignored and that it is managed as best as possible. This is recommendations for how often you should do blood monitoring and monitoring of BMI and waist circumference. Another possible problem, we see this more often with the typical antipsychotics. It's called neuromalignant syndrome or neuroleptic malignant syndrome. Person presents with hyperthermia, muscle rigidity, autonomic dysregulation, mental confusion, hot, stiff, and out of it. And this may sound to you a little bit like serotonin syndrome, and it does. And this chart is to highlight the differences between serotonin syndrome and neuroleptic malignant syndrome. Serotonin syndrome is more likely to have hyperreflexia and myoclonus and shivering, restlessness and agitation, Katie's study was a study of the clinical antipsychotic trials of intervention effectiveness. It occurred in 2001 to 2004 at 57 clinical sites. There were 3 phases, and it showed that clozapine may be the most effective, but that Zyprexa and risperidone were very tolerable, although they can both cause a significant amount of weight gain. This study did not include Abilify. It did not include any of the first-generation antipsychotics, and since then, we have several more second-generation antipsychotics that are very different. So, some things to consider when you are switching atypical antipsychotics. So, what you want to do is cross-titrate. Do not abruptly stop one and start another one, as this can cause activation of symptoms, breakthrough of symptoms. You should not allow gaps between administration of one antipsychotic and another one, and do not start the second antipsychotic at full dose. Things to remember: the penes are usually sedating, the dones can be either, and the pips and the rip in comparison are activating. This is how not to switch. You don't stop one and wait a week and start another one. Don't do that. This would be an acceptable polypharmacy, switching from one sedating antipsychotic to another one. You would cross-titrate each drug over a period of a week. You also do not want to get trapped in a cross-titration, meaning you start reducing the first one and you start the second one, but you never finish getting the patient off the first antipsychotic. You need to carry that through and get rid of the first one. Switching from a pene or done to another. So this would be penes to penes or dones to dones. You can switch over the period of 1 week. So you could reduce the pene by 50% while you're starting the new pene at 50% at the same time, and then drop out the first one completely at the end of the week and increase the new one to full dose by the end of the first week. To switch from a pene to a done, remember the penes are very sedating, you're going to give it 2 weeks to stop the pene. So you're going to reduce it gradually over that time. Clozapine is a little different. Clozapine needs to be reduced slowly over 4 weeks just by itself. If you're going to switch from a done to a pene, you will again titrate the pene over 2 weeks while you can get the person off the done over the course of 1 week. So in general, whether the person is coming off or going on to a pene, you're doing it over the course of 2 weeks, unless it's a pene directly to a pene. So from a done to a pene, you will start the pene slowly over 2 weeks. Switching to aripiprazole from a pene. So a pene to a pip. More likely to cause breakthrough symptoms. So you want to start the aripiprazole at a middle dose and titrate it up over about a week, but you are going to reduce the pain again over 2 weeks. Switching to aripiprazole from a DONE. So a DONE to a PIP. Again, start the aripiprazole at a middle dose, and the DONE can be increased over a week, and the aripiprazole can be increased over a week, but also start at the middle dose of aripiprazole, not at a super low dose. If you are going from aripiprazole to a peen, stop the aripiprazole. It's got a really long half-life, and start the peen at a middle dose and titrate over 2 weeks. So that's pretty consistent all along, that the peen, you're either reducing it or increasing it over a span of 2 weeks. With the DONE, you are also going to stop the aripiprazole and start the DONE at a middle dose and titrate up over a week. There's also a very good website. It's called switchrx.com. That can be very helpful in reminding you how to make the switch. And then in closing, this is showing us the psychopharmacological targeting of circuits associated with violence. And as you know, there are times when schizophrenia patients can become quite violent.